Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today, June 27th, 2018, for our Medical and Surgical Oncology lecture. A couple of preliminaries and then we'll meet our guest and get started. If you are having any technical difficulties, please call us right now, 919-445-1000. Let us know what's going on. We'll do our very best to take care of this. Of course, this is being recorded, so you'll have the opportunity to see it afterwards as well if you need to go back and view the recording. We're available by email at unccn@unc.edu, and you can find us on the web at unccn.org. We're on Facebook, Twitter, lots of places you can find us. We'll be using Poll Everywhere for an icebreaker question at the beginning and then for our Q&A session at the end. So there are two ways you can join us on Poll Everywhere. One of them is to go ahead and on any phone that has texting capabilities, in the to field you can type in 22333, the number 22333, and then in the message field type in UNCCN. You only need to do that one time. It will indicate join, and then you can go ahead and answer our questions. Our question at the beginning and then ask your questions, and we hope that you'll have several to share with us at the end of the presentation. Another way to join us in Poll Everywhere is to go to pollev, pollev.com/UNCCN. So pollev.com/UNCCN. You can go ahead and ask and answer questions there as well. All right. That's what this looks like, and our question, our first Poll Everywhere question, this is the icebreaker just to make sure that the tool is working for you. What word or phrase comes to mind when considering challenges to treating breast cancer? So if you can put in a word or phrase there, and we'll look at that in just a moment. All right. So without further ado, welcome, Dr. Lisa Carey. Thank you so much for being here with us today.
My pleasure.
Let's see. I've got some bio information for you. Let's see if we've got this right. Richardson and Marilyn Jacobs Pryor, Distinguished Professor in Breast Cancer Research, Board Certified in Medical Oncology, Chief of Hematology Oncology, Physician-in-Chief at the NC Cancer Hospital, Associate Director for Clinical Research at the Lineberger Comprehensive Cancer Center.
That's right.
And I have here that interests include examination of different subtypes of breast cancer, evaluation of new chemotherapy agents in early breast cancer, and examination of tumor characteristics that predict response to therapy.
That's right.
Is that pretty much accurate? Does that sum it up
That's
reasonably
pretty good,
well?
yeah.
What's something I left off the list? What's one thing you might tell our viewers today that wasn't on there?
That's not a professional
Could
title.
be something non-professional or professional.
So my family would say I have a high tolerance for chaos. I live in a house with 4 kids and 3 dogs, and the husband and me.
Wow. So, well, thank you so much. We are really thrilled to have you here. Let's take a look at that Poll Everywhere poll and aggressive, nausea. So the nausea, the aggressiveness, the potential aggressiveness of the disease. And we'll wait for just a moment to see if anything else will come in there. And so hopefully everyone had an opportunity to go ahead and at least join that Poll Everywhere tool. If you didn't, you feel free to do that so that you can go ahead and share questions with us a little later. And without further ado, I'll turn this all over to you, using biomarkers to plan adjuvant therapy in breast cancer.
Thank you. So I'm going to talk about biomarkers in the early breast cancer setting and how we use biomarkers. I'm going to start out with the practical part of this, and then I'll move into slightly wonkier parts. So bear with me during the wonky parts because I think it's actually sort of the interesting future directions. So the first is to state the obvious, which is in early breast cancer, our understanding of prognosis and treatment decision-making is predicated on 2 main categories of elements. The first is anatomic features, specifically where the cancer is and isn't. You know, what's the size of the tumor? Does it involve the local lymph nodes? Is there evidence of distant spread or not? Which, of course, if there is, then it's no longer early breast cancer. And then on the right, the biologic features, which have traditionally been related to grade to some extent, which gives you a sense of aggressiveness in a somewhat crude way, and then the therapeutically targetable proteins, ER, PR, and HER2. So if we talk about biomarkers, you have to sort of start with what does it take? We all hear about all sorts of biomarkers, and we all get contacted by people who have their favorite biomarker or people who have developed one in their garage that they say will help with decision making in breast and other cancers. And I always like to use this slide just to remind us that assay development and using it in the clinic really requires that any biomarker has gone through this whole series of really bridges that have to be crossed before you know that you can believe in the assay. The first is whether the assay has been shown to be analytically valid, and you'll hear these terms tossed around frequently, so it's good to know what they mean. Analytically valid means the assay itself is reproducible. If you do the same one on the same tumor over and over, you're going to get the same result. And it's accurate. It actually represents what it's supposed to represent. Does it represent hormonal signaling? Does it represent proliferation? Whatever that is, it's been shown to do that. The second is it clinically valid? Does it actually take cancers and differentiate them into categories that are useful, right? Hormone receptor positive, hormone receptor negative, for example. And then the third is clinically useful, and that's the last step. That's showing that using the assay actually lets you make better decisions in a way that's meaningful for the patients you take care of. That's where we spend most of our time. So here's an example just of the clinical utility. We know, for example, that hormone receptors, right, as represented by protein assays for the estrogen receptor, actually help us make therapeutically better decisions, because we know if they don't have hormone receptors in the breast cancer, then the likelihood of endocrine therapy working is, as you can see, is 1.0. It doesn't do anything, right? Giving tamoxifen is irrelevant in a hormone receptor negative cancer. Conversely, in a tumor that's been tested and shown to be hormone receptor positive, you see the substantial impact that we're all familiar with of giving endocrine therapy to these tumors. This is a very old example of clinical utility studies, and this is why we don't give endocrine therapy to hormone receptor negative tumors. So a couple things as we're talking about biomarkers, and partly because of the effectiveness of the tests that we use already and the drugs that we use, and pairing those together, breast cancers are doing better, all early breast cancers are doing better now than they were even a couple of decades ago, because the chemotherapy is better, because the endocrine therapy is better, and we're targeting it more thoughtfully, and we have developed both assays and therapies for anti-HER2. And so if you look from the left of the slide to the right, you can see all categories of breast cancers are doing better now. And so that's where we have the problem of overtreatment and trying to be a little more rational, not give everybody all the therapies we can. So I use this as an example. It wasn't that long ago. It was when I was first starting out in faculty that there was a National Institutes of Health, the NIH, had a consensus conference where they brought in a whole bunch of key opinion leaders and experts to decide when we should give chemotherapy. This was one of their questions. When do we give chemotherapy to breast cancer patients? And basically this quote is from that consensus conference. It says you should give chemotherapy to most women with breast cancers bigger than 1 centimeter, period. So, the bar was set pretty low, and most of our patients got chemotherapy because of that. But I mentioned overtreatment. Even then, we had a problem of overtreatment. So I'm showing you here a classic study that was used actually in the development of one of our tests that we use, the Oncotype DX recurrence score. In this study, you can see that there is clearly a statistically significant benefit of adding chemotherapy, right? The red dotted line went up to the blue line, and that's the benefit of chemotherapy in this largely node-negative population of patients that were postmenopausal. And so this is a positive study, is why we gave chemotherapy to this particular relatively low-risk group. But realize the 88% of the patients in the red dotted lines didn't need chemotherapy because they were going to do fine with just endocrine therapy. Conversely, all the people above the blue line relapsed anyway, and so the chemotherapy didn't help them. So in truth, the benefit of the chemotherapy, now this is a low-risk population, but it is one that we used to treat, is only 4%. So those are the people that were benefiting, and that's a big problem. So in the early 2000s, most patients who fit in this category, because that consensus conference, because it couldn't tell who the 4% were, and this is, if you relapse, you're likely to die, then they got chemo. And most of them, we all knew even then, didn't benefit. So this is where many of the problem that we all recognize and the problem that we faced and the reason for the development of so many of these largely RNA-based assays and biomarkers that help us make thoughtful decisions in hormone receptor positive breast cancer. And here's some of the names. These are the commercial assays, and we have access to most of them in the U.S., although not all of them. And the reason they work is because breast cancer is itself heterogeneous. And I think, this is I think those of us who work at UNC are contractually obligated to show these kind of things because this work was developed here. And it basically shows us that if you ignore things like relapse or treatment response, or if you just say, is breast cancer 1, 2, 3, or 9 diseases, basically you come up with this kind of result no matter how you do it, which is you get about 5 or 6. If you want to get really fancy, you can get subsets within subsets, but you get about, up to 5 different diseases that will reproducibly segregate themselves based on biology. And this is the reason that these assays work. We know that it isn't just biology. The biology is also part of prognosis. So if you take a group of patients who are basically untreated, you will get, this is the natural history of those over even a short period of time, treated with surgery and radiation, but not with systemic therapy, you can see that there are some subtypes of cancer that tend to do better no matter what you do. And there are some subtypes, like that luminal A up on the top. And there's some subtypes that do worse, like the HER2-enriched subtype, if no matter what, and that's pretty reproducible, and that's actually where we're trying to direct our targeting. It's also true that timing matters, and I think this is important in hormone receptor positive breast cancer. That's the practical considerations here, because the luminal A breast cancer, you can see that while patients are relapsing in that high blue bar, only about 20% of them, even without treatment, relapsed in that group. Conversely, the yellow bar is luminal B. And luminal B looks to me and to the pathologist pretty similar to luminal A. We can't tell them apart under the microscope, but you can see that while it starts out doing okay, it keeps going. And even after 5 years, when the triple negatives, which make up most of the red bar, and the HER2 enriched, which make up most of the gray bar, if they make it to 5 years, it's actually relatively uncommon for them to relapse. The luminal Bs, this is where late relapses come in, and that's actually a big problem I'm going to talk about later. So again, our clinical phenotypes of breast cancer are hormone receptor positive breast cancers, of which some can be also HER2 positive. HER2 positive, who can be either half are about hormone receptor positive and half are hormone receptor negative, and then the triple negative, which basically is they don't have any of our therapeutic targets. They don't have either ER or PR or HER2, so that's where the triple negative name came from. It doesn't tell you what they do respond to, it does tell you what they don't. So most patients are hormone receptor positive and HER2 negative, and that's in the orange bar on the top, and we're going to talk about those first. So the key therapy for them is anti-estrogen therapy, so it's endocrine therapy given for 5 to 10 years, and the main question up front is, are these the ones who are going to benefit from the addition of chemotherapy before you start the endocrine therapy or not? So the clinical questions in hormone, and I'm using HR positive, meaning hormone receptor positive, and ER positive a little bit interchangeably because it's a little unusual to be ER negative and PR positive, although technically those are also hormone receptor positive. We just group the ER and PR together into hormone receptor positive. So what we want to know in these, as I just mentioned, is who needs chemo? Who's going to benefit from chemo? And that's for our patients. That's the key question that they want to know up front. The second question is, who needs longer than 5 years of therapy? Because we have data that going to 10 years is actually beneficial for these anti-estrogen pills that they take every day. But there's toxicity of these things, so we want to be a little bit more thoughtful. That one's a harder nut to crack, although there's some data that I'll show you in a second. And then what we don't yet know is identifying those in whom we can do nothing. We can just give them their surgery with or without the radiation and give no medical therapy at all. There's clearly some who need none of our drugs, but we really don't have a way of finding that out yet. So this is, you don't need to memorize all this stuff. This is just to show you that the assays that we use, these commercial assays, were all developed very thoughtfully. There's a couple of different algorithms that assay developers use to try and create these assays. And if you read through, you will see there's several different approaches that were used in all of these ones. They work, but they are not the same assay, but they're all RNA based, and they all basically came up with some similar findings, even though they approached it differently, with the key part being that all of these assays are dominated by genes that are relevant for hormonal signaling, right? So there's no surprises here. They may have approached it slightly differently, but in truth, they are picking up on similar biology. Even if if you look at them, sort of wonky people might have, when these first started coming out, started looking at them saying, well, they must all have the same genes in them. Well, they don't, but they all have the same pathways represented, and in truth, they are similar to some degree, although they are not identical. So here's just some of the data that came out, earlier and more recently, testing these assays in what we call prospective retrospective studies. And all that means, that's a term that's used to reflect and test a study that was done, prospective clinical trials. So the trials themselves are very valuable information. It was collected ahead of time. They're not missing a lot of information, etc. And then they went back and tested the original cancer. So that's why it's called prospective retrospective. And the nice thing about those studies is because they're very high quality studies, and the patients were treated uniformly, right, because they were on a trial. And as you can see, in these studies where the patients had hormone receptor positive disease, they were all treated with anti-estrogen therapy and not chemotherapy, right? So pretty uniformly. You can see that the recurrence score on the top segregates by the score, the low risk group, an intermediate group, and a high risk group, similar to what we call the prosigna, low, medium, and high, and then something called the EP-clin, low, medium, high. So they all give you sort of similar results. So the first one that was available, or certainly that was tested extensively, is something called the MammaPrint. The MammaPrint had 70 genes. It was developed very thoughtfully, where they developed the genes first, tested them. The assay was available based on these prospective retrospective studies because it looked promising. It was generating the kind of data I showed you in the previous slide. And it was launched in Europe about close to 15 years ago. And then it got FDA approval in 2007, but wasn't used very much because the only way it could be done was on frozen tissue, which most of our pathology banks don't have frozen tissues because they get put in formalin and fixed. In 2015, they showed that the test works as well in fixed samples, which is the more conventional way to process tumors, and it's become quite commonly used. It's very expensive. This number, $4,200, is what it costs. It's about the same for all of these assays. Typically, that's less than chemo costs, so they would say it's cost effective, but they're really expensive. So MINDACT actually was the first to come up with a prospective trial where the trial was developed explicitly to show the benefit of the drug, of the assay, in helping you make decisions. And that was published in the New England Journal about 2 years ago now, not quite. And they used the 70 gene signature is the MammaPrint signature. And they basically said, we're going to test this, and we're going to call our test, our study, a success if the patients are without, the proportion of patients without distant disease, distant relapses, in those in whom we normally would give chemo, so they were clinically high enough risk that we would normally give them chemo, but when we test them with the MammaPrint, they're genomically low risk, who don't get chemo. If it's at least 92%, if that proportion, meaning only 8% have gotten distant metastases, we're going to call it a success, and we'll say we've done well, and this is a valuable assay. What they actually found was their distant metastasis-free survival proportion in that group of patients, who are almost all hormone receptor positive and HER2 negative, was 95%. So they clearly met their threshold for saying, this is valuable. You can in this group of patients, you don't have to give chemotherapy because you're not going to do better than 95%. So a couple of things to note about this study. A, it's a huge study with 7,000 patients, of whom the group that's outlined in red here are the ones that I just mentioned. So they were clinically high risk, but their genomic test says they're low risk. And then they get randomized to get chemotherapy or not. The group that didn't get chemo was the 95% group, and the group that got chemo was barely better than that, and certainly not significantly so. But I've highlighted this a little bit to make the point that it's a low-risk group of patients. About 40% had no greater than 2 centimeters of tumor. Most were node negative. Most were low grade. They were virtually all hormone receptor positive, and only a minority was HER2 positive. There were, for example, virtually no triple negatives in this data set, although technically they were allowed. The whole population did well. So doctors being doctors, they didn't put their patients on the study unless they were comfortable with the patient not getting chemo. And so they ended up with an entirely low-risk population. The other comment which should be noted is this really wasn't designed to test chemotherapy effect. It wasn't powered. It wasn't created for that. And there was a little bit of a difference, a couple percentage points, which is 22% proportional. Absolutely, since the risk was so low, it wasn't much higher than that. We can't say that genomic low-risk cancers, if you got a much higher risk group of patients, like a stage 3 cancer, we can't say that chemotherapy wouldn't benefit them, that you can use this genomic test all by itself and say that it's meaningful. We cannot say that. And I wouldn't use this test in a really high clinical risk group of patients, like stages 3 particularly. So what about the Oncotype DX? So this just came out, their prospective level 1 evidence trial. This assay has been available since 2006. It's been used a lot in the U.S. Most of the time when they test how the assay is being used, it's used to not give chemo. So it's actually used in a very good way. It's very similar, I'm sure it's by coincidence, but all these assays cost about the same. And it's been recommended by ASCO, by the NCCN, by Cancer Care Ontario, and all based on these previous prospective, retrospective data. There were 2 studies that were designed to explicitly test the assay. One was called TAILOR-X, that's the one that was just reported about 3 weeks ago, and the other one's called Responder. Responder is in node-positive breast cancer patients, so higher clinical risk patients. It has not reported, but we do have the data from TAILOR-X, which I'll show you. So TAILOR-X was reported at ASCO, and then on June 4th or whatever, and simultaneously published in the New England Journal, and this is the article, if you want to see it, the same day, first week in June. The Oncotype DX is a 21-gene assay, so that's this. And the point of the TAILOR-X was to look at specifically chemotherapy benefit in intermediate score, recurrent scored patients in node-negative hormone receptor-positive cancers. They second wanted to confirm that those that have really low scores, which they'd already reported that those with really low scores, there's no randomization. They were just observing how they did. They all received only anti-estrogen therapy, and they wanted to confirm that with follow-up they were still doing well and you were still safe with doing endocrine therapy only. So here's the schema. So this was these are all large studies. So this was 10,000 patients registered, of which, remember, so Arm A was those with really low scores. There was no randomization. They just got endocrine therapy, and they were followed. On the far right are those with high scores, we would say sort of medium to high scores, and they got chemo and anti-estrogen therapy, and they were just followed. It's the ones in the middle that was the key randomization, where half of them got endocrine therapy alone and half of them got chemotherapy and endocrine therapy. So if we focus on that group, because that was the main finding that was reported in that New England Journal article and at ASCO, so it's about 7,000 patients, again, split evenly. And a couple of things are important. First off, they used a different cut point than those of us who use this assay in the clinic are used to. So usually the cut points for calling something low is a recurrence score of 18. And the cut point for calling something high is at 31. So here, for practical reasons, they shifted everything over so that low was actually less than 11 or up to 11. And high was 25 or higher, or over 25. So they've shifted everything over. The second is that this is what's called a non-inferiority trial. And what that means is they can't say that something is better, but they can say something isn't worse. And that's the point of this. They wanted to say that in their hypothesis was that giving endocrine therapy alone would not be worse than doing something more aggressive with chemo, and that's how they designed the trial. And they set that threshold saying 1.32, meaning no more than 32% difference would be allowed for them to say it's not inferior. So, like MIND-ACT, the doctors did not put high-risk patients into the study. So you couldn't have a tumor bigger than 5 centimeters. In truth, the median cancer in this trial was only 1.5 centimeters, and that IQR means interquartile range, so the 25th to the 75th percentile only went up to 2. So this was and it's all node negative, so this was virtually all stage 1 cancers. About 2/3 of them or so were in that medium grade where we really don't know what to do with it. And I think it's worth noting that 74% of the patients in TAILOR-X had what MIND-ACT would have categorized as clinical low risk. And in MIND-ACT, because of the design of MIND-ACT, at the end of the day, they said for those patients, don't even get an assay. You don't need to get an assay because they'll be low. So I think that question of who do you actually don't need to get an assay in is a question that hasn't yet been answered for this particular population. So the first question was, are they continuing to do well if they've got a really low score and they're treated only with anti-estrogens? Is there any reason to worry about giving chemo to these patients? No. Short answer is no. At 9 years out, 97% of them did not have any distant metastases. These patients are doing great. So that's an easy one. So the second one is, what about the randomized population between the sort of low to low intermediate up to medium intermediate, right, which is a randomized group. And you can see here, so that Kaplan-Meier curve has 2 curves in it, one with chemo and one without. And it's not too hard to say, there's really no evidence of an impact of chemotherapy here. So the whole group is doing well, right? So there were only 12 events, and events here is a variety of things. It's contralateral disease, it's relapse locally, and it's distant mets. And only 1/4 of those, what they consider to be events, were actually distant metastases. So it's a minority, and this is now 7.5 years out. So their actual margin, the hazard ratio between the chemo-treated group and the non-chemo-treated group was 1.08. which is well within the non-inferiority margin. So they can say, and they did conclude, endocrine therapy alone in this setting is not inferior to endocrine therapy plus chemo, so why would you give chemo? So I want to take a minute just to look at the endpoints, the invasive disease-free survival endpoint that they use, and just point out that in that invasive disease-free survival endpoint are a variety of events. Distant mets, which all of us would argue is clinically meaningful and where chemotherapy is likely, if there is an impact, it's going to impact on that. Local recurrence, which there's also an impact of chemo. It's a little less clearly life-threatening, but it's something that we treat. But then there's 2 other things, second primary cancers and death without recurrence, meaning you get hit by a truck or something, right? Neither of which do we think is related to the chemotherapy receipt or not, but is included in the events, and to some degree creates statistical noise. So if we just look at those other endpoints, and I think honing down on the things that we really think are clinically meaningful, in the randomized arms, everybody's doing great. So if you use the MIND-ACT criteria and said, as long as they're doing at least 92%, they are for both relapse-free disease, so they really relapse-free of any kind, meaning distant or local, or distant relapse-free, they're 94%. So everybody's doing great. Arm D, which is the group that got chemo and anti-estrogen therapy because they had a high score of 25 or greater, they actually are doing worse. So it's not that the entire population is well. There is a poorer prognosis within that Arm D, which is driven partly by the genomics, but also partly by the clinical scenario. So the population that ended up with the higher genomic risk is largely those that are higher clinical risk also, and only 43% of them, compared to 74%, have clinical low-risk disease. So they're doing worse, 76% invasive disease-free survival, and in fact, almost 15% of them had distant mets at this point, even though they got chemo. So, the population did have some poorer risk patients. So the funny thing that they found, and it's not really funny because it's complicating things, is they did exploratory analyses by subsets, and one of the things that popped out when they looked at sort of obvious places to examine is a interaction with age and whether chemotherapy started to benefit. And you can see if we start with the bottom, on the bottom are women over 50 in TAILOR-X who got randomized. So it's just those 2 arms. So remember, this is the recurrence score of 11 to 25. And you can see that those two curves, the hashed lines are the confidence intervals. So ignore them for the time being and just focus on the solid lines are pretty much together the whole way across. So the improvement with chemo is virtually none in patients who are older. Now on the top are patients who are no older than 50 years. And what you start to see is the red line and the blue line start to diverge they actually are crossing at 13, but you start to see a significant divergence really somewhere around 20 or so is when it starts to get big enough where you might think of adding chemo, right? If you're getting a 6% benefit with chemo, that actually is something that you would probably discuss with the patient and probably offer. When they did the same kind of analysis just using menopausal status and disease-free survival, they saw the same thing. That's in that little forest plot that's embedded in the middle. So a couple of caveats about this, just focusing on that younger woman thing, it was an exploratory analysis, number one. Number two, it wasn't a planned analysis. So we always have to be a little leery of being too strong about recommendations based on an exploratory analysis. The second is we don't know exactly why there's an interaction with age, and one of the possibilities is that this is actually less about chemo than about the known impact of chemotherapy on ovarian function. So this may be simply the chemotherapy effect on ovarian suppression. The patients in this trial largely did not receive ovarian suppression, so whether you could simply supplant chemo with that is absolutely not known, but it is a reasonable question. So this was, I had the pleasure of giving the discussion of TAILORx at the ASCO's plenary session. So this was my money slide, or at least my effort at a money slide, which is how are you actually going to use this? And knowing what we know now and recognizing the imperfections of what we know, this is where you could reasonably land in terms of using the recurrence score for treatment decision making in, again, node negative patients in whom you think chemotherapy is appropriate. So again, this is not a microinvasive DCIS population. This is this group of patients. It's also not a stage 3 population, right? I wouldn't use it in them. But in stages 1 and low 2s, this is how I would use it. Postmenopausal women, we now have very good data that endocrine therapy alone is fine up to a recurrence score of 25. Now from previous, and the red stuff is because this is new knowledge, the black is where I think we already knew things. We've long known that patients with recurrence scores of 31 and higher tend to have a high relapse risk if all you do is endocrine therapy. That's been the standard, and that's still true. This didn't change that. So somewhere between 25 and 31, you start seeing the benefit of chemotherapy. Where exactly that happens, I don't know, but it's somewhere in there. So you're going to have to, in that group, use clinical variables to help you gauge when you're going to add chemo, but you've now narrowed it down. We used to not know between 18 and 31. Now we know it's somewhere between 25 and 31. Premenopausal women, sort of now the cut point starts to happen somewhere between the 16, 18 and 25 based on the curves separating. I don't think there was a lot in the 11 up to 16 or so. And if you ask the statisticians for TAILORx, they said they started to see the curves shifting somewhere around 20 and greater, but in truth it's a continuous variable, and so somewhere in that realm you would start to consider chemotherapy. And because of that finding in TAILORx, it's quite reasonable to say that if chemotherapy starts to kick in and you get to somewhere to 5 to 10% absolute benefit by 25, it's certainly going to benefit when you get above 25. So I think now, while they didn't test that in it, it's quite rational to assume that. So I would say above 25 in a younger woman is when I would certainly consider it more standard than not. So let me talk quickly about some of the other endpoints, because that's the most practical element and certainly where we are today with decision making. So Prosigna. Prosigna is another assay. It's based on the PAM50 intrinsic subtyping with some other elements that are folded in that are proprietary, but they have to do with proliferation and things like that. And it gives you data like this, which segregates patients by risk over time and in fact includes late relapses, as you can see, and we'll get into that in a second. It works in node-positive breast cancer, so it actually has been tested a little more formally than some of the other assays in node-involved cancers, and here's two of the studies that involved lymph node positive breast cancers treated with endocrine therapy alone. And you can see some the point is the low group would actually are doing really quite well. And so then you could theoretically say you don't need to add chemo. This is part of the reason for these things moving into the node positive group, is because this is really another place we need some help. Another thing that it does is it tends to segregate by late versus early relapse and works reasonably equally in both, which is nice. So late relapse, if you know that, you can reasonably, if you know something is not, a patient's tumor is not at risk for late relapse, you can reasonably stop after 5 years, because that's how the studies were designed. This looked at late relapse. If you only receive 5 years of endocrine therapy, if you know that their low risk for that is low, like the blue one here, then if it's less than 5%, why would you give them 5 more years of an aromatase inhibitor? So these assays have been endorsed widely. They're not going to be any less endorsed now with 2 large level 1 studies coming up with relatively similar endorsements of using them in clinical decision making. I'm underlining this part because it's worth saying these assays cannot replace clinical variables, because in each case, as the clinical risk goes up, the genomic risk starts to change, and you can't generalize from studies in largely stage 1 for TAILOR-X, or stage 1 slightly into stage 2 for MIND-ACT for higher risk patients. So let's talk a little more about late relapse. So ASCO last year, and then subsequently published in the New England Journal, is some actual kind of harder data regarding late relapse. And you can see here, this is from the Oxford overview, where they took 46,000 women treated with 5 years of endocrine therapy and on clinical trials, and looked to see what happened after that. And they did find that there's a higher risk of late relapse than I think many of our trials had previously appreciated. I'm going to say with some caveats, because these are older trials and we know that all patients are doing better now than they were. But the truth is, it's, usual clinical variables matter, tumor size, nodal involvement, etc. And there's even a risk for stage 1 cancers of after that 5th year and up to the 15th year or 20th year. This is my reminder that no matter what we talk about when we talk about these assays, you will see this in the little write-up for all these assays. You see it in the Agendia write-up. You see it in the Prosigna write-up. It'll say, like, insert their name, provided significant additional information on distant relapse after endocrine therapy. And the question is, does it mean it's prognostic? Does it mean the clinical variables are prognostic, or both? And of course the answer is both, because in all of these studies, the clinical variables remain highly prognostic. You cannot replace the clinical variables with any of these tests. So I'm going to keep reminding us of that, because there's a tendency for the genomic test to become the dominant one. So this is another look at late relapse. This was the ATAC, Mitch Dowsett, and the trans-ATAC effort at what some of us would call a bake-off amongst the different commercial assays, specifically looking at late relapse. If you look at node negative, you actually get some sense that the ROR, which is the Prosigna output, and the BCI, which is the breast cancer index, seem to give you some data, and then one called EP-CLIN, which is EndoPredict, which is not available in the US, I don't think, or at least it wasn't until recently. All seem to add a little bit to the clinical variables, where's that dotted yellow line, where some of the others, including the recurrence score and I think MammaPrint wasn't tested in this, but the recurrence score a little less so, although they're trying to tweak it so that they can try and address that. In node positive, none of them seem to help all that much. And again, that's probably because the likelihood of relapse is driven so much by the clinical variables that the test becomes less useful. Oh, I'm going backwards, sorry. So a couple challenges in this, and then I'm going to turn to the sort of fun future direction-y stuff. So level 1 evidence for biomarker utility is really hard. It's really expensive and it's really hard to do. MIND-ACT cost about $50 million. I don't know what TAILOR-X costs. It has to be at least that. These are super expensive, so it's not realistic to say that we should test every single assay using this approach. We're going to have to be more thoughtful about it. This is where I think the lower level of evidence can help us if you've got a reasonable population. I actually am a believer in the prospective retrospective trial approach to this. You need to have it be coming from different sources and be consistent, but I think we can do it, and we absolutely cannot keep doing $50 million trials for every assay that comes along. So we're going to have to be more nimble. Couple of other conceptual things. So I'm going to get into the wonky part. Those of you who want to eat your sandwiches now. So the first is, it's also true that the assays may not be, you get one sample and you test one sample. If you were to test an entire tumor, you may get, or if you were to sort of do cores throughout an entire cancer, realize that there's data that you may get discordance in those results across that tumor, which is why they're not perfect. This was a study, and it's just an example of how often when they kind of went around to play parts that looked a little bit different from one another within one cancer and said how often did the tests themselves come up with discordant results. And you can see on the bottom that the best was the MammaPrint, then the PAM50, which is the Prosigna ROR1, then the Oncotype. And there's a little bit of a relationship between the number of genes that are in the assay and the likelihood of them remaining consistent. And that's probably not too surprising, because the more genes you have, the more you're representing kind of the totality of the tumor biology. If you're just relying on a handful of genes, you're more likely to have noise in there. But the truth is that all of them had some discordance, and it may well be that the cancers have intratumoral heterogeneity. They may also have heterogeneity over time that I'm going to talk about next. So what are some of the other clinical questions in early breast cancer? And this is where we get into, well, actually not just early, I want to talk about metastatic at the end, but this is where we start getting into future directions. So the first is actually kind of a short one, triple negative. So triple negative breast cancer is molecularly heterogeneous in a way that we don't have a test for. So I'm showing you three different approaches, from the upper left to the lower right, to examining triple negative biology. And basically, and what I've outlined in purple is essentially the same findings using different approaches. And they do tend to fall into bins that might be targetable, with some being more or less prone to DNA damage repair aberrations, which might allow for sensitivity to certain chemotherapies. Some are more driven by growth factor aberrations and being autoactivated. Some, the androgen receptor pathway, so there might be a hormonal element in some, and some are the immune activation, which may or may not be targetable. This is one of those approaches. All I would say is, and this is to my mind the one I'm the happiest with, I think this one is the most likely to make it into a clinical assay, is this MD Anderson subtyping. But the other approaches have a lot of overlap with this, and they're all characterized by sort of similar signatures that relate to immune signature, androgen receptors, growth factor pathways, and DNA damage repair. It does not matter at this point in terms of chemotherapy. If you're going to give chemotherapy, it doesn't yet help us with treatment decisions, but they're working on it, and it wouldn't surprise me if it did in the future. So now what about HER2 positive disease? So this is, of course, the laundry list of drugs that we use in HER2 positive breast cancer. They all involve lots of chemotherapy, and at least 1, 2, and now 3 HER2 targeted drugs if you include extended therapy with neratinib. They're all super expensive. There's one that's not on here, which is for stage 1, the APT regimen. So that's the only one that limits the chemo and limits the HER2 targeting, but it's only used in hormone receptor positive, HER2 positive stage 1, so it's very limited still, but we want to get to that. So who actually benefits from all the HER2 targeting? Separate out the chemotherapy. In truth, we know that in general, adding the extra HER2 targeting does help. Certainly in the neoadjuvant setting, where you have a higher risk patient and you have something that's easy to measure, you can see that pretty consistently adding a second anti-HER2 drug is better than just one, but there's a lot of variability here. We also know that the molecular subtypes within HER2 positive disease are broadly applicable, right? You can see here that in clinical HER2 positive disease on the right, so you see all the subtypes are sort of showing up there, luminal subtypes, HER2 subtypes, even basal-like. And on the left, you see clinical HER2 negative. You see HER2 enriched molecular subtype is even showing up in 7% of those. So this is true that clinical HER2 positive disease is very, very heterogeneous. There may be some therapeutic implications for that. So on the top is the CALGB 40601. Many of you participated in this. It was a UNC-led trial through the CALGB. We did intrinsic subtyping at the same time that we did the clinical trial, and you can see that no matter THL, TH, and TL are the three treatment arms of the study, and it sort of didn't matter. No matter which arm the patient was on, the tumor responded better if it was the HER2-enriched molecular subtype, like 2 times as much, which was a bigger difference than the treatment mattered, right? So you have a bigger impact of the tumor factors than the drugs we gave. There's a separate thing that immune signatures also had this kind of impact. So that's a challenge because we don't capture this information very regularly, but it's also an opportunity. If you know something's hypersensitive to HER2 targeting, you may not need to use as many drugs. On the right-hand side is a very intriguing report that came out in JAMA Oncology where they looked at hormone receptor-positive metastatic breast cancer. These patients are HER2 negative, but when they did molecular subtyping, they turned out to be their HER2-enriched molecular subtype. Even clinically, you would never give them HER2-directed therapy. The trial was a trial of lapatinib, and you can see there's some suggestion that the molecular subtype may trump the clinical subtype from the standpoint of benefiting from HER2 targeting. So now finally, my last couple slides have to do with metastatic breast cancer. And so here's the sort of treatment algorithm that we all use for treating metastatic breast cancer, which is if it's hormone receptor positive, you start with antiestrogens, you continue on antiestrogens until it's clear that they're not working, at which point you go to chemotherapy. If they're hormone receptor negative, you start with chemotherapy and you add HER2 targeting if they're HER2 positive, and that's basically our approach. It's pretty crude and it hasn't changed much in the last number of years. So I already showed you this, which just is the highlighting of the molecular heterogeneity of the primary tumor. It is likely to be worse when you get to relapse disease because the relapse disease has already had the opportunity to change either on its own over time or because of the selective pressure of the drugs. But when we're treating on the basis of, for metastatic disease, we're still treating on the basis of the primary cancer. And there are some studies, there's not much data, but there's some studies that suggest that it may matter. This was a study that looked at de novo stage 4 disease. This is the primary tumor in an untreated population of patients, but they did a recurrence score on these patients and then said, did it matter for the metastatic disease? And if you look on the left-hand side is the patients who received endocrine therapy as their first treatment. On the right-hand side was the patients who got chemotherapy as their first thing. It was not chosen on the basis of their recurrence score. It was simply chosen by the doctor based on what their own paradigm would be for this patient, what I call clinical voodoo sometimes. And in truth, you were worse off substantially if the doctor chose to treat you with endocrine therapy first, which is all of our guidelines say use endocrine therapy first, and most, as you can see, 71% of these patients did. But if you made the wrong call and the patient had a genomically aggressive cancer and you treat with endocrine therapy worse, their overall survival was worse. So that may be that we can get some information from these kind of tests in metastatic disease. This is really preliminary data, but we're going to pursue this, and I'll show you how. And I actually just showed you this, so I think I put it in there. So I'm going to finish with sort of something that's coming because it might be of interest to you. It's probably going to start in the fall. It's a trial called Harmony. Harmony is all metastatic breast cancer patients. They've had no more than one prior treatment. They have to actually be in their first treatment after developing metastatic. They can be right before starting it or during it. What we're going to do is we are going to do molecular analysis of the primary breast cancer. We'll get an intrinsic subtype, and we will tell the treating physician what that intrinsic subtype is. So if you have a patient who has a HER2 negative breast cancer, but it's HER2 enriched, we're going to tell you that. We're not going to direct therapy, but we want to know how often is the information that we get from doing this therapeutically meaningful to you, the treating physician. You may or may not ever be able to actually give the patient treatment directed to that, but we're going to ask you whether, if you could, would it change your perceived treatment options? We're going to do a whole bunch of other molecular analyses on this that we won't be reporting back, but we'll be reporting when we do the final analysis. But the intrinsic subtype we'll get back within 4 weeks. So the second is we're going to do the same thing with the metastatic cancer because it's possible that you get better biologic information from the MET than you do from the primary breast cancer. We're going to do all the same studies in that. So the objectives in this is we think it'd be clinically meaningful to know the molecular subtype of the cancer if the difference between what you think the cancer is going to be, if it's hormone receptor positive, HER2 negative, you think it's going to be a luminal tumor. If it's not a luminal tumor, then that's incongruous with what you think it should be. If that rate's at least 15%, then that's actually something that we, the treating physicians, would probably want to know about. The second is a simpler question, which is, does it change your perceived treatment options, what your optimal approach to this patient would be? Does this knowledge help you? It's not just whether it's different than what you expected, but does it actually help you from a treatment standpoint using the drugs we have right now? And those are the two main objectives. So to summarize, first, I keep saying this because it's I think one of the things that gets lost in the noise of excitement about these genomic assays is they don't replace clinical variables. Clinical variables are, if anything, more important. They're certainly no less important than they were before. But in hormone receptor positive, HER2 negative early disease, we have multiple assays that work very well to help guide our decisions about who would benefit from chemo and who shouldn't. They may help with late, extended adjuvant endocrine therapy. That's a work in progress, but there's good data that it may. We shouldn't use unvalidated assays to override standardized clinical assays. So if somebody has an assay that they say is going to tell you something better than ER using the more validated way, I wouldn't take them at their word and I wouldn't use the assay. Triple negative in HER2 disease, the heterogeneity is real. It's opportunities, but that's where we have some real challenges still. Thank you very much.
All right. And Dr. Carey, thank you. We're going to go ahead and open this up to questions. So let me just remind everyone, you can either just go to polev.com/UNCCN and type in your questions there, or if you didn't already, right at the beginning, now's a great opportunity to text the letters UNCCN to the number 22333, get a join message back, and then you can go ahead and share your questions with Dr. Carey. So while we're waiting for those to come in, you mentioned the expense of the assays, and they really, that $4,500 cost. Is there any reason to expect that there'll be opportunities to see those prices drop? Are there technologies that may be applied, mechanisms that...
Yes.
Mm-hmm.
I mean, I think, as we get into greater emphasis in value-based care,
Mm-hmm.
I think there will be pressure to bring these down, just as there has been with every other technology.
Right.
Not in the near future, but
Okay.
I'm believing it in a someday.
Okay, good. And looks like I see UNCCN. I'm assuming that's not a question. I think we've just got a couple of folks figuring out how to get the submission in place. You're just back from ASCO recently.
Yeah.
Anything that particularly piqued your interest in terms of studies being released relevant to your work?
Well, I mean, Taylor X was reported there. That was hugely important. I have to say the things that seemed the most important were some nice studies with targeted therapies that were looking promising. I think we're still figuring out the PI3 kinase inhibitor universe, but there were some promising studies with both PI3 kinase inhibitors and AKT inhibitors. Again, we need to figure out how to identify them, really effectively. So I mean, I think the idea in breast cancer of being a little more targeted remains a holy grail, though. I think one of the problems that we have is the emphasis on DNA sequencing, which has been so helpful in lung cancer and melanoma and things like that. It's not as useful in breast cancer, so these other RNA-based things I think are going to be much more promising.
Good.
And there are a couple studies that suggested that.
Good. Well, we do have questions coming in now. How many cases of inflammatory breast cancer are you seeing?
Well, so inflammatory breast cancer, using the strictest definition, is somewhere around 5 to 10% of our population, which is about what it is nationwide. It's not a big number. I define inflammatory breast cancer as it has to have induration, it has to have an erysipeloid edge, peau d'orange changes, and it has to be at least 2/3 of the breast. The problem that you run into is a little bit of, if you see dermal lymphatic invasion, then that's a pathognomonic finding, but most of the time you don't see that. The problem you have is if you have a lot of bulky lymph nodes, sometimes it looks inflammatory, but it really isn't, so you have to be a little bit critical about that. It doesn't matter a lot in terms of treatment. We don't at the moment, we don't have inflammatory directed therapies, although there's people working on that.
I want to interject for just a moment. I saw a comment that somebody was having trouble with Poll Everywhere. If you are having any trouble with Poll Everywhere this afternoon, you can just email your question to unccn@unc.edu, and then John will relay that to me, so that either through text or on the screen, so that we can relay that question. Do you have pathology automatically order genomics in greater than half-centimeter tumors, or still base the need for ordering on MEDOC decision?
Yeah, we don't do it automatically. Usually there's a conversation with the patient about if the patient says, I would never take chemo, I had an uncle who had lung cancer and I would just never do it, then there's no point in getting the test. Or somebody who said, if there's any possibility that something will help me, then I'm going to do it, I'm going to take it. Then I don't get it. But it becomes relatively automatic in the patients who are fitting in both the MIND-ACT and the Taylor-X populations. The surgeons, in our case, a lot of times will do the sussing out of the patients and get a sense of that, and they get it kind of teed up for us. So it's happening more regularly, although it's not automatic technically.
All right. Well, we are nearing the end of the hour, so we should probably wrap up. I do apologize to anyone who had trouble getting through with Poll Everywhere, and please do feel free to relay those questions to unccn@unc.edu, and we can forward those on to Dr. Carey. One more. Two more. Is the genomic testing insurance covered? We'll take these last two.
Yeah, if it fits the criteria, yes, it is. If it fits the criteria that were used in the studies and that the FDA has the approval for.
Great. And have there been any studies done looking at differences in predictions for treatment of tumors that convert from HER2 negative at time to a diagnosis of HER2 positive?
No, not formally, although I would say that tumors that are HER2 positive, there's certainly, everyone has these sort of series, and if they're HER2 positive, then there's certainly series that suggest that treating with HER2-directed therapy is a reasonable thing to do, and most of us would do it. Whether there's heterogeneity in the converted ones versus the ones that were positive from the very beginning, I think is as yet unknown.
All right. Well, thank you very much. Let me just mention a few things here. We want to thank the North Carolina General Assembly for their generous support of the UNC Lineberger Comprehensive Cancer Center through the UCRF, or University Cancer Research Fund. We want to thank Mary King, Veneranda Obore, and John Powell for all the hard work that they do to make this and every one of our lectures possible. We have more lectures always coming up. Our next RN and Allied Health lecture will be on July 11th, and that's Palliative Care Opportunities with Nicole Sartor. And then our Medical and Surgical Oncology lecture, the next one is July 25th, also at noon, and that's Novel Molecularly Targeted Therapies and Biomarkers in Advanced Colorectal Cancer with Dr. Lee. We hope you'll be able to join us for both of those. If you can't join us at the live lecture, you can go online at unccn.org and sign up through our learning portal to take that anytime within the next year, and that includes this lecture as well. You watch the lecture, you take and pass a short test, and we can go ahead and award you credit. And that's free, whether that's, in today's case, for CME, CNE, or ASRT. Please spread the word that we're very proud to make this lecture and all of our lectures freely available for that continuing education credit. Find us on the web, call us, email us, find us on Facebook, like us on Facebook, find us on Twitter, YouTube, LinkedIn. We keep expanding. So Dr. Carey, it has been a real pleasure to have you here today. Thank you so much. All right. And thanks to our audience. We value you and always appreciate your attendance and your interest and your participation. All right. Until next time.